All right, today we're jumping right into a clinical debrief. We're looking at a case of catheter-directed thrombolysis, or CDT, that went critically wrong. Our whole goal here is to break down exactly what happened, step by step, so we can all understand how to prevent something like this from ever happening again.
So let's meet the patient. He's a 54-year-old man, a diabetic, and a longtime smoker who comes in with a gangrenous foot. Not good. The angiogram gives us the full picture, a complete aortoiliac thrombosis. We're talking a massive clot that's blocking all blood flow from the aorta down to his legs. The team on call decides to go in with catheter-directed thrombolysis. Now, on paper, that sounds like a reasonable plan. But in reality, it turned into an absolute catastrophe. So that brings us to the central question of this whole debrief. What on earth went wrong?
Let's just trace the timeline because it's terrifyingly fast. Within a single 24-hour period of starting CDT, the patient develops excruciating abdominal pain. Then his labs they fall off a cliff. His INR, that measure of blood clotting, shoots up to 5. His fibrinogen crashes to a dangerously low 40. And at the exact same time, the access site in his arm, it develops full-thickness necrosis. We're talking a complete systemic collapse.
Okay, so our debrief is going to focus on 3 major points to really understand this failure. And we're going to start with the first one, the fundamental choices made about the access site and the thrombolytic agent. So, the very first mistake happened before a single drop of the drug was even infused. This was a foundational error, a mistake in basic procedural planning, the choice of where to even access the arterial system. The team went with the brachial artery in the arm. The problem? It's a non-compressible site, and it's notorious for having a high rate of complications. And in this case, it led directly to thrombosis and necrosis of the limb. Now, the guideline is crystal clear on this. You use the femoral artery. Why? Because it's easily compressible, which dramatically lowers the risk of an uncontrollable bleed. So, the wrong access site was mistake number 1. Mistake number 2 was just as critical. The choice of the clot-busting drug itself. They chose streptokinase. And for this procedure, that drug has a really dangerous profile. It has low clot specificity and a high risk of systemic lysis. What that means is it doesn't just dissolve the target clot, it starts dissolving clotting factors all over the body. The standard of care alteplase, or TPA, is the complete opposite. It's highly specific to the clot and has a very low systemic risk. I mean, the right choice here should have been a no-brainer. And here's the direct, ugly consequence. By choosing streptokinase, they kicked off systemic fibrinolysis. This is exactly what caused the patient's fibrinogen to plummet to 40, which then triggered overt disseminated intravascular coagulation, or DIC. That's a nightmare state where you're bleeding and clotting all at the same time. Right, so this leads us straight to our second debrief point. You have a poor procedural plan already in motion, and then it gets compounded by some really critical lapses in monitoring. Look, CDT is an active, dynamic process. It is absolutely not a set it and forget it kind of infusion. The complications that come with it, they are almost always preventable, but only if you have rigorous by-the-book monitoring. And this is the non-negotiable protocol. At a bare minimum, you're checking these key labs every 6 hours. And just look at that first line. Fibrinogen. The action threshold couldn't be clearer. If it falls below 100, you stop the infusion. Period. End of story. Let's just focus on that number, because it is the most important one on the screen. 100. That number is the safety net. It's the hard stop designed specifically to prevent that terrible cascade into DIC. And in our patient's case, that safety net completely failed. His fibrinogen didn't just dip below 100, it cratered all the way down to 40 before anyone even recognized what was happening. That bright red stop sign was completely blown through. Which brings us to our third and final debriefing point. And this one actually takes a step back from the procedure itself, because this error happened before the patient even got to the angio suite. It's all about patient selection. We have to ask the most fundamental question of all. Even if the procedure had been done absolutely perfectly, was this the right patient for CDT in the first place? So, this here lays out the decision-making framework using what's called the Rutherford classification. CDT is really best for a Class 2B limb, one that's in immediate danger but is still salvageable. Our patient, though, with established gangrene, he very likely had a class 3 limb, and that means irreversible ischemia, a situation where CDT is actually contraindicated. The correct path here probably would have been primary surgery or even amputation, not thrombolysis. And honestly, there were other glaring red flags. The patient already had an active infection from wet gangrene. That means he was already septic, which basically primes the body for DIC and just dramatically amplifies all the complications you can get from any thrombolytic therapy. So, what's the big takeaway from all these errors in selection, in procedure, and in monitoring? Well, it all boils down to a clear, simple safety protocol that has to be followed.
You can really summarize this protocol in 5 critical rules. 1. Choose femoral access. 2. Use a clot-specific agent like Eltaplace. 3. You have to monitor fibrinogen every 6 hours. 4. You must respect that hard stop point of 100 milligrams per deciliter. And 5, probably the most important of all, choose the right patient to begin with and avoid CDT in anyone with irreversible ischemia.
Every single one of these 5 rules is based on well-established, evidence-based guidelines, which really leaves us with a final, pretty provocative question to think about. If the evidence is so clear, why do these completely preventable errors still happen in practice?